All right, welcome back, guys. This is going to be the start of our anatomy series. We're on episode 2. This is going to have a little bit of a different vibe from the last episode if you watched it. We talked a lot more about sports and stuff we'll see with concussions and stuff like that. This one's going to be a little bit more of a slow crawl and kind of maybe hard to get through if you're not one with anatomy. We're going to be covering the foot and ankle and the anatomy behind it, and as well as some of the biomechanics that lead into that. So bear with it. It may be a little boring, but this is going to be good material to study off of and to test your knowledge and just see where you're at before your comps, if you're taking comps, or just in your general practice, what you remember. So yeah, enjoy, try to get through it, and thanks for watching. And without further ado, Vito's going to jump into some basic stuff with the foot.
Great. So PT students studying for their competencies this early, like us, or even if you just want a quick refresher as a undergrad or first year or anyone who wants to, this would be a good place to start. We're starting with the regions of the foot. Hind foot is going to be the talus sitting on top of the calcaneus. And then midfoot moves forward to the naviculars, cuboids, and cuneiforms. We'll have our image up here, as you can see. 7 and 6 is the talus and the calcaneus. Right in front of that, on the left is 5 navicular, all the way on the lateral aspect. Number 4 is the cuboid, and then from medial to lateral, 1, 2, 3 is the medial, intermediate, and lateral cuneiform. That is all makes up the midfoot. And then the forefoot starts with the metatarsals, goes from digit number 1, that's going to be the hallux, the big toe, all of that, all the way to the lateral side, which is, digiti minimi or pinky toe, whatever you want to call it. But that metatarsals, proximal phalanges, intermediate phalanges, distal phalanges is all going to make up that forefoot. Primary joints we're going to look at from a proximal aspect, including the ankle, just because it ties into management of the ankle, is going to be the proximal distal tib fib, which is up near the knee. That moves down towards the distal tib fib joint. And then the first, or the primary ankle joint we talk about, is the talocurl, or the TC joint. Right underneath that, in between the talus and the calcaneus, is the subtalar joint. Moving forward are the transverse tarsal joints, intertarsal joints, tarsometatarsal joints, the MTPs. Nope. TMTs. Then you have the metatarsal phalanges. Those are the MTPs. And then all your interphalanges in between that. Let's go ahead and move on to ligaments. Back to you.
Yeah. So obviously we need all these bones to connect somehow, some way. So some primary ligaments that we're going to have in the anterior portion, we're going to have the tibiofibular ligament. That's obviously going to connect tibia and fibula. It's going to prevent that twisting motion that we see in the ankle, and it's going to allow for some movement during the dorsiflexion when talus moves up into that joint. Also on the lateral aspect, we're going to have the anterior talofibular ligament, ATFL, the calcaneofibular ligament, and the bifurcated ligament. All of those ligaments on that side are going to help prevent that lateral shift and limit the range that it has. On the posterior side, we have the posterior tib fib, posterior talofibular ligament, and the posterior tibial talar, or part of the deltoid ligament. And in conjunction with that, we also have the tibiocalcaneal ligament on that deltoid side as well. So big giant ligament on the medial side, and as you see in the next episode, it has a lot less injury rate on that side because of its sheer size. Also, it's going to help resist eversion, and then we're going to have some spring ligaments with the calcaneonavicular ligament on that side as well. And then going into some of the fascia that we have, that's also going to help keep everything kind of packed into its place on the ankle. We have the inferior extensor retinaculum, and then we have the dorsal fascia of the foot, and then we have the plantar aponeurosis. And all those structures help maintain the integrity of all the ligaments and tendons that are moving around into that foot and helping it function as well as possible. And then right here, we're going to move into the foot musculature, and then Vito's going to take over that piece for us.
All right. So we had an awesome professor for our anatomy, Mr. Cliff Barnes, Dr. Cliff Barnes. And so straight from his guide sheet, on the dorsum of the foot, the primary muscles that we're going to look at are the extensor digitorum brevis and the extensor hallucis brevis. Both brevis meaning the shorter muscle, so it's mostly running along just the dorsum of the foot, not really crossing the ankle. Both are supplied with a deep fibular nerve. Primary roots are L5S1. So dorsum of the foot, extensor digitorum and hallucis brevis, deep fib L5S1. After we go over the dorsum of the foot, the shifts to the plantar side. So we're going to work through these 4 layers, starting most superficially, so the closest to the skin. The 3 primary muscles and the most superficial layer are the abductor, abductor hallucis, abductor digiti minimi, and then our main flexor group, which is the flexor digitorum brevis muscle. Both the abductor hallucis and the flexor digitorum brevis are going to be supplied with the medial plantar nerve, S1, S2. Abductor digiti minimi, it's on the lateral side, so it's going to be the lateral plantar nerve, S2, S3. Then we're going to get a little bit deeper. We have our quadratus plantae. That's going to be supplied by the lateral plantar nerve, S2, S3, as well as the lateral lumbricals, lateral plantar nerve, S2, S3, medial lumbricals on the medial side, medial plantar nerve, S2, S3. Third layer, so getting a little bit deeper again, we have our flexor hallucis brevis, same side, it's on the medial side, medial plantar nerve, adductor hallucis, it's on the lateral side, lateral plantar nerve, and then the flexor digiti minimi brevis. So that flexing that pinky toe, all those nerve roots are S2, S3, as well as the 4th and deepest layers. These are the plantar interossei and the dorsal interossei. Both are going to be lateral plantar nerve, S2, S3. So the deeper we go, the lower down that nerve root we go as well. So that covers most of the foot musculature that you're going to need to know for anatomy. Then we're going to move up the chain to our crural musculature or the lower leg, whatever you want to call it. In the anterior compartment, we got our 4 main muscles, tibialis anterior. We test all the time. It's always in your myotomes. You should know where it is. It's right along that just lateral surface of the tibia, and it's supplied by the deep fibular nerve, L4, L5. Extensor hallucis longus, so the big long muscle that helps lift up the great toe, deep fib, L4, L5. And then the extensor digitorum longus, the rest of the extensors for the toes, deep fib, L4, L5. Also here we have our fibularis tertius or peroneus tertius, very short muscle. Same thing, deep fib, L4, L5. So if you're seeing any muscle in that interior compartment, it's going to be supplied by the deep fibular nerve. When we shift to the lateral compartment, we have 2 main muscles here, peroneus longus and peroneus brevis. They're both going to be supplied by the superficial peroneal nerve, L5S1, S2. And we know they're on the lateral side because those are the ones that are running just behind the lateral malleolus and also contributes to our eversion at the ankle. In our posterior compartment of the leg, we got 2 levels. We have our superficial ones. Those are the ones we know and love, the gastroc soleus complex, separated into 2 different ones here. It's the tibial nerve, S1, S2, and then up by the knee, plantaris, also is part of that superficial group, and it's going to be supplied by the tibial nerve, S1, S2. That's the superficial group. Going deeper on the posterior side, we have popliteus inside that knee joint, tibialis, L4, L5, S1. Then we have our flexors, flexor hallucis longus, flexor digitorum longus. Those are both going to be supplied with the tibial nerve, S2, S3. And then lastly, tibialis posterior, tib, L4, L5. All those wrap in behind the medial malleolus.
All right.
And then let's go into our nerves.
Cool. So big main nerve roots that we have are going to be our tibial nerve and our common fibular nerve. Okay. Tibial nerve is going to be made up of L4 through S3 nerve roots. They're going to mainly innervate the posterior compartment. Okay. So that's going to be all those muscles that Vito just listed off just a second ago. And they're going to end on the medial and lateral plantar nerves. And then we have the common fibular nerve. That's going to divide into the superficial and the deep fibular nerve. Okay. The deep fibular is going to innervate the anterior crural compartment. So TA, all those muscles that Vito listed off earlier. And then we have our superficial fibular nerve. And that's going to be innervating muscles of the lateral compartment. So a lot of those fibularis, brevis, and tertius in primary. And so we're going to see posterior lateral and anterior crural intermuscular septum where it comes through. And then moving on, we're going to go into, should we save shin splints for a little bit
Yeah.
later?
Yeah.
Okay. So we're going to move into some of the biomechanics of the foot. So the ankle's main motions, as we know, are plantar flexion and dorsiflexion. That we're going to have that loose pack position. So when the ankle is at its most loose or most playful position in motion is going to be at that 20 degrees plantar flexion. And then we have our closed pack position when it's going to be max dorsiflexion. And that's because of the shape of the talus. It's more of this like V, almost knuckle shape. So the higher into dorsiflexion you go, the more cinched that talus is going to be into the bottom of the tibia and fibula. And so that's going to go into our talocrural coupling. So leg external rotation is going to help supinate the foot. And that's basically when the foot goes into a sort of inversion. So almost like the plantar surface comes up towards the medial side, and then leg internal rotation is going to move the foot into that more pronated or everted position. So we're going to see a lot of that. And then Vito, do you want to talk about foot function?
Yep.
On
So
stability?
just kind of playing off of that. So when the foot is pronating, it's going to be its most mobile. So you can think about, if you look at your hand, this knuckle, if you push it down on the table, all of the bones and ligaments are going to be at their most stretched and playful. And now the foot is really mobile, it can move around. When we supinate, everything tightens up, the bones slide over to the ligaments are locked up because the muscles are pulling it together. And now the foot is stiff. It's something you'll see during push off, and actually kind of goes to the next part. So we have the primary arch of the foot is the medial longitudinal arch. It's supported by all the muscles and the ligaments, but when we think about that push going into that stretch position, it would be the most mobile. Then it stretches all the soft tissue, the fascia, the muscles, and that all stiffens up. So it's dissipating force. And as soon as we go to that push off, all that tension that's generated helps snap into that stiff position and then push off again. So there's a nice shock absorption as we go through pronation. It's going to a mobile position, everything tightens up, then we supinate as we push off, stiffen everything, and gives us that power as we go through, a sprint mechanic, any sort of push off, like a lunge, a jump, plyometrics, and all that sort of stuff. Then if we want to look forward at our next joint, so the subtalar joint with the TC, those move a little bit. They move related because they're sitting on top of each other. So the plantar flexion of the talus, like we were talking, if you're plantar flexing, the talus is sliding forward. It's moving out of the tib fib, out from in between the tib fib, so it's more lax up there. Underneath, you have the calcaneus everting just a little bit, and that just switches as you come back up. As you dorsiflex, head of that or the front of that talus is moving up, widening up the tib fib, and the calcaneus inverts just a little bit. And that pretty much covers what we were going to cover in this section. I know it's super boring. It's a lot of words. We're going to throw the pictures up here. So if you were looking at this for anatomy review, watch the YouTube video, tie it to the pictures, press pause, rewrite it, whatever you need to do. Vince, what else do you want to throw in here?
Not much. I think one thing I found that we kind of liked as we went through what to talk about was the difference between shoe-based running and barefoot running, and the two kind of schools of thought. When people think of the biomechanics of the foot, a lot of people stem to the, is barefoot running better than shoe running? And that primarily goes into the whole, like, how are we naturally supposed to move our feet, and do we go back to our ancestral like mindset of like, oh, we didn't wear shoes back in 3,000 years ago, so why not wear them? Why not wear shoes now? And personally, I don't believe in the barefoot movement necessarily. I believe in the anatomically sound shoe and kind of meeting in the middle of those two schools of thought. I don't know. What were your thoughts when we talked?
I think I lie a little bit towards it depends. Ah, man, it's a tough question because we don't have a patient here in front of us with a specific set of goals. Um, I think our feet are built to be very, very efficient at running. However, nature versus nurture, as we develop certain movement patterns. As we develop, our bones respond to the stresses that we put on them. Our muscles respond to the stresses we put on them. If someone's having pain and they think it's going to help them, if they think it's going to help them, it probably will. We need to teach them how to do it safely. That just goes into the patient mindset. I mean, if a patient believes in an intervention, it's more likely to be effective. But I would never recommend changing someone's running pattern unless they think or bring it up, in my opinion. But I think that's why people differ, because I can see where it has value. I am just under don't fix what isn't broken, focus on the things that people want to be fixed. Now, when it comes to this toe box and making sure it's a well-fitting shoe that supports the movement that they're trying to do, I'm all in.
Right. I think that's more where I kind of lie. As long as the simple mechanics stay integral and that we're making sure that their mechanics are at their ideal piece. And whether they run barefoot or not, as long as we're keeping the integrity of their foot intact and there's no pain provoked in either way, I think they're free to do whatever they want. But yeah, I agree. One thing I kind of found interesting was during our course, the Lieberman 2010 study talking about foot strike patterns between habitual barefoot and shoe runners, and seeing how shoe runners have a two peak force impact during the time where it's a significant heel contact peak and then forefoot contact peak, where the midfoot runners are going to have more of a smooth single peak pattern during their strikes. So where a shoe runner will have basically two big points as they strike the ground, and a non-shoe will roll across, to make sense of it and put it simply. And I just found that kind of interesting, and doesn't mean that one's better than the other necessarily. It's just that with habitual wearing or non-wearing, you're going to see different kind of kinematics transfer onto someone's like running pattern.
It is interesting. It was a really fun lab when we all had everyone run and walk and to see who does what. And
Yeah.
almost all of us are going to be heel contact strikers. And the
Right.
second you take your shoes off, and you try to do a heel contact, you're like, oh, that does not feel good. Um,
Yeah. It almost, yeah, it almost pushes you into that uh, 4 foot kind of running pattern just out of comfort, because running barefoot and still trying to keep that same shoe wear pattern while running is not the most comfortable and causes for adjustment. But yeah, other than that, that was one of the main things I kind of wanted to bring back up during this first episode of it.
yep. All right. Well, I think that covers the very quick overview of function and anatomy for quick and easy review. And I know it's super boring. Watch the YouTube video, pause it, look at the images, use it as a quick study tool as you go with your competency exams.
Yeah.
Because that's what we're planning
Pause
on
it.
doing.
Yeah. Pause at any moment. Just see what you know, see what you don't know, and use this to refresh yourself. All
Yeah.
right. If you made it through, thank you so much for watching, and catch us on the next video.